Carpenter. I'd like to thank you for taking the time to join me on this video. This is the final video in a three-part series on physical examination for conditions around the knee. And we're finishing up now with physical examination maneuvers for the assessment of Chondromalacia Patella. Chondromalacia Patella. Now, Chondromalacia Patella describes a softening and a swelling of the cartilage on the undersurface of the patella. So our physical exam for Chondromalacia Patella begins with inspection. So a couple things that we're going to inspect for with chondromalacia include any atrophy of the quadricep muscles, particularly the vastus medialis muscle, any signs of inflammation around the knee such as redness, swelling or increase in size, tissue tightness. Going to look for any sign of skin changes that would indicate long-term nerve damage to the knee. We're going to look for any signs of bursitis in the prepatellar bursa, the infrapatellar bursa, and any of the bursa around the knee. In fact, some references indicate that there are as many as 17 bursa around the knee. Then we're going to perform some palpation, and specifically for this condition, the palpation is unique because we're going to try to palpate the under surfaces of the patella to attempt to reproduce pain in the examinee. So to palpate the patella, we can palpate the medial aspect of the patella and the lateral aspect of the patella, and we can get our fingers underneath there if we displace the patella first in the trochlear groove and then get underneath it with our fingers like so. Now, it is possible that with extensive or advanced chondromalacia, the cartilage on the undersurface of the patella could be tender, in which case the examinee will give us some indication of pain, either through a subjective report of symptoms or a reflexive withdrawal to draw the patella back in its trochlear groove. So we palpate the medial aspect of the patella, and then we palpate the lateral aspect of the patella, looking for any jump sign or any indication of pathology of the patella. Then, as we talked about with the assessment of patellar instability, a couple of key measurements are important. We won't reproduce those here because we've already done those, but we want to measure the Q angle, and we also want to measure the insole ratio. Now, it's interesting that with the insole ratio, when the length of the patellar tendon becomes elongated in relation to the height of the patella, that creates a condition that we call patella alta. And with patella alta, there's altered biomechanics of the patella within the trochlear groove, and this leads to accelerated development of chondromalacia. So that's an important part of the physical examination, is the calculation of the insole ratio. Then our physical exam proceeds on with range of motion testing. And with regards to range of motion testing, what's important is that you palpate the kneecap as the knee goes through progressively increasing angles of knee flexion. As the patella rises up in the trochlear groove, it's most likely that we're going to find chondromalacia high in the trochlear groove versus low in the trochlear groove. So you want to palpate the patella for crepitus at increasing angles of knee flexion. So let's demonstrate that. So I have my hand here on top of the patella, and chondromalacia of the patella would palpate as a sensation of sand or little pebbles in the joint, or grating or grinding coming from the joint. So that's what we're feeling for. So you place your hand over the top of the patella as you take the knee through progressive angles of knee flexion. And it's at these increasing angles of knee flexion where you're most likely to feel any crepitus or grating or grinding if it is indeed present. So important to palpate. as you go through the range of motion. Then, with regards to our physical examination maneuvers, there's really two maneuvers that we rely on most for assessment of chondromalacia. And that is the Patellar Grind test and the Waldron's maneuver. Now, I'm sure you're familiar with the Patellar Grind maneuver, but I found that doctors perform this in many different ways. And my intention is to standardize the method for the performance of the Patellar Grind. Now, textbooks describe this maneuver as involving an inferiorward directed force against the patella as the examinee contracts their quadricep muscles in an attempt to raise the patella in the trochlear groove. And what's missing from these descriptions is the instruction to make sure not to compress the patella within the trochlear groove. We're simply trying to apply an inferiorly directed force to the patella and not compress the patella. So the Patellar Grind maneuver involves the doctor taking the web of his hand and cupping the superior pole of the patella with the web of the hand and applying an inferior force tangential to the axis of the leg, not compressive into the trochlear groove. It's tangential down the line of the leg or the axis of the leg. And then you ask the examinee to tighten up their kneecap by straightening the leg. Beautiful. And the kneecap will rise, and you're assessing for number 1, pain, number 2, reflex inhibition of the quadricep muscles. In other words, these muscles would go weak, or any type of reflexive withdrawal where the examinee demonstrates that they're unwilling to do this maneuver. Okay, so let's repeat that. And loosen. So there's the patella. Here's the superior pole of the patella. Take the web space of my hand and apply a force tangential, not compressive. That would hurt even a normal teenage knee. Okay, so the force is directed tangentially, and tighten up your knee, please. And you can see that this examinee has good strength. The kneecap tracks vertically in the trochlear groove. There's no reflex inhibition, and there's no report of pain. So that would be a negative Patellar Grind test. And then finally we finish up with the Waldron's maneuver. Now, the purpose of Waldron's maneuver is to attempt to correlate any crepitus that comes from the joint with any pain that the examinee reports. Now, the AMA guides provide for permanent impairment due to chondromalacia when two circumstances are evident. Number 1 is that there's crepitus on physical exam, and then number 2 is that the crepitus is painful. See, it's possible to have crepitus in the absence of pain, and many people have crepitus from their kneecaps. They'll tell you that when they go down the stairs, it sounds like there's sand in their joint, or that their knees are grinding. But this is not painful crepitus, and that crepitus does not impair activities of daily living. But the AMA guides do provide for permanent impairment when there's pain, and when the pain is associated or due to the crepitus. There's an interesting distinction there. So we use Waldron's maneuver to attempt to associate the crepitus with the pain. So with the Waldron's maneuver, we ask the examinee to go through a repetitive squat maneuver while we as the examiner palpate the patella for the crepitus. Now, the crepitus will come on as the knee goes through range of motion, and generally the crepitus comes on as the knee goes into deeper and deeper and deeper ranges of motion. So we palpate for the crepitus. The crepitus should be associated with a report of pain by the examinee. So let me demonstrate that here. If you palpate the crepitus at, for example, 45 degrees of knee flexion, you palpate crepitus, but there's no report of pain by the examinee, that's a negative Waldron's maneuver. If the examinee reports pain at 15 degrees of knee flexion, but you palpate the crepitus at 45 degrees of knee flexion, that's a negative Waldron's maneuver. A positive Waldron's maneuver would be when the examinee reports pain, ow, that hurts, right at the point at which you palpate the crepitus. And that way we say that the crepitus and the pain are associated. So let's demonstrate the Waldron's maneuver. Okay, with the Waldron's maneuver, you as the examinee palpate the patella by placing your hands medially and laterally over the patella. And then you ask your examinee to do repetitive squat maneuver as low as they can, and you attempt to palpate for the crepitus and associate that with any report of pain. Okay, so let's demonstrate a false positive or a non-physiologic exam finding. Okay, so report pain early in the motion.
Ow.
There's a positive report of pain, but no crepitus. That would be a negative Waldron's. Okay, continue down and report pain.
Pain. Ow.
Okay, and up. And in this case, she reports pain at 90 degrees of knee flexion, but I palpate crepitus at 30 degrees of knee flexion. That would be a negative Waldron's. Okay, and one more time. And report pain.
Ow.
Ow. And in this case, she reports pain right at the point at which I palpate the crepitus. The pain is associated with the crepitus. That would be a positive finding for the Waldron's maneuver. So there is your physical examination for Chondromalacia Patella. Always include your x-ray studies and measure the cartilage intervals on both the lateral and the merchant views. And you'll have a complete physical exam for Chondromalacia Patella. This is Dr. Perry Carpenter. I hope this helps you a lot, and I look forward to being with you on future videos. And for now, I'm wishing you best of success.